Okay, big regulatory grant program aside, I will go through these relatively quickly. These are more general slides of the value of doing these programs generally in rural health. Um, but I also want to make sure we leave at least 15 minutes for Q&A. So I'll go through them relatively quickly. Everyone's going to get these slides. So first, what's the value in a rural setting, right, for remote care management? CCM, RPM, APCM. Expanded access, right? Reduced travel, better clinical outcomes, more engagement, more stickiness with patients, revenue, which is a big deal now given right the sort of the challenges facing rural hospitals and clinics, and then expanding care team capacity. The first thing you have to sort of figure out is what care programs you want to utilize. There are three main care programs in the rural health context. Those are APCM and CCM, which are the care management things, the care management programs. They don't require a device. They just require time spent between visits each month. APCM is really not taking over, but it is becoming more and more valuable in the rural context for a couple reasons. One is it does not take the specific amount of time. So staffing requirements are a little bit lower on APCM. And two, the proportion of patients, the way APCM gets reimbursed is by condition. So it's a population health program. You enroll your patient in APCM, and we have another webinar that we went over APCM, and we'll link in the thing that we send out after this webinar, sort of the basic thing for each of these programs. So we want to go over it here. But the takeaway here is, in rural context, the proportion of patients who are qualified Medicare beneficiary dual enrolled is much higher than in urban populations. So this final APCM category, QMB with 2+ chronic conditions where the payment is so high, has a much higher rate of being the case per patient in a patient population that's rural. So APCM, because of that, generally pays more, as it should, right? Because these are indigent patients that have more barriers to access and care and things like that. But because of that, in the rural setting, we're seeing more APCM programs than CCM programs. And then what you do is you do APCM, and then for the patients that qualify and can benefit, you add a device to that patient. You do RPM for the patients with hypertension or CHF or COPD or whatever you might be doing for that. And together, that is one, interaction with a patient and touch points with the patient that you wouldn't otherwise have, but that you're getting paid to have. So it's a new revenue source, while at the same time, you're talking to your patients a little bit more, but you're also now able to bill for a lot of the time that you're already spending helping patients because you're a medical office that needs to tell patients about their diet and help them call in medications and try to figure out what's more affordable for them, right? Or get access to things. So you're doing a lot of this work already, usually. And this sort of allows you to do that and build these programs out where you can have them within a reimbursable model. So again, going relatively quickly, and this is part of your grant process too if you're doing RSPP, is what kind of device you'll be using for if you're doing an RPM program. Those generally fall within Bluetooth or cellular, depending on your patient population and how tech savvy they are. Especially in rural areas, again, we're biased here, but cellular usually is a lower lift. But these are things that you'll have to sort of figure out. 2 more slides before really going into a summary and then Q&A. One is the 3 things that you really need to decide on when you're looking for a remote care to launch a remote care program. One is the software side. Most EMRs, the vast majority of EMRs, don't really provide meaningful areas for these programs to be managed. So often you have to look for a third-party software or platform that centralizes the remote care, what devices you need, and then, and this is true with the RHTP too, do you need outsourcing help? You don't have to staff the program internally when it comes to these remote care programs. You can use an outsourced vendor if you want to. We're one of those, but also we're software only too. So the idea is, how much bandwidth do you have, given the extra money that you'll be getting, and sort of where do you want that to sit? This is true with RHTP funds or with a fee-for-service program. which goes into the staffing model, right? Which is not to keep harping on it, but insource, you're doing it yourself. Outsource, there's a third party that's doing the not practicing medicine with your patients, but doing the general care management and then escalating it back to you or your your clinical staff or physicians or other providers when needed, or sort of a hybrid where there might be some things being done by the vendor. Maybe they're calling the patient to do initial setup and consent in and things like that, and then there's some amount of work still being done internally. Most vendors do really just pure outsource, but there are a few that have these us included, that have both the hybrid and the software only options. When you're getting started, again, we'll share these slides, but figure out your target conditions. You want to sell your providers and clinical staff on the value of the program. Make sure you do organizational awareness and training. You're starting small and then scaling, although with RHTP, that's less a thing. You're really for hitting the ground running, so make sure you preparation in that case. And then for patients, for care managers, the people that are actually doing this work, it's making sure that you have time to educate them on how to do it, right? Make sure that there's good care plans that are set up, that the technology is there, and they have support from the technology vendor as far as how to use the technology and how to what are the best practices for doing these services and workflow and things like that. We have quite a few groups that will offer incentives for productivity and efficiency for care managers in the realm. And then finally, making sure that you really do a good job setting up initial expectations with patients. This is explaining the time commitment, what these programs are, why they're really valuable. And there's a lot of data to show that they're really valuable. Who's going to be involved, right? Copays, if they're applicable. If it's grant funding, they won't be. If they're joint enrolled, it won't be. But some small proportion, not small, but some proportion of patients will have a copay. Make sure that they know that that's going to happen, so that when the $8 bill comes in, they don't show up at the office yelling bloody murder, right? Just setting expectations, super important. Final takeaways before Q&A. The new code, this is a really good time to start these programs. With RHTP funding or without. These are meaningful patient programs that are additional modalities of care that really this year and last, rural health providers have really been given the tools from the reimbursement and revenue side of this to do these programs at scale, and in a way that is good for their bottom line, while doing it in a way that Medicare and Medicaid are looking for sort of shifts already, right? They want more chronic condition management. They want more between visit care. They want more interaction with the patient and clinical staff between provider visits. And that's the reason that they're paying, significant amounts for these programs. And urban programs were very lucrative upfront. The changes really have made these more and more able to be done in the rural context with smaller patient volumes, still big patient volumes, but sometimes smaller. And with now the reimbursement's really caught up to the cost of doing it, and then some. We had folks already making a 15-20% margin on these services in rural health before the changes, but between 15 and now it's, I don't know, 25-30. It makes it's not bupkis. It makes a big difference, right, when you're scaling these out. Choosing the right partner is really important. Right? Having someone who not just is good at RPM CCM and has a platform or outsourcing, but also knows the rural context, especially if you're an F2HC or an RHC. Everything is different. Billing is different. Are you going to the local MAC or the national MAC? Do you need to have different coding based on if it's there's just a lot. There's a lot. So making sure that you have a partner who knows that is important. So when you're doing your diligence, just it's worthwhile to ask for a few references, or at the very least make sure that they that you have a good feel for them knowing what they're doing. And then finally, if you would like to learn more about again, do the initial Google. But if you're interested, or I guess if you just want more information in general about grant opportunities that you may be eligible for, your organization might be eligible for, don't hesitate to reach out. We are happy to walk through or do a bit of research on our side. This is a big part of our business going forward for the next couple of years. And we are making sure that we are subject matter experts, and we are happy to share some of that expertise with you. Even if we don't do something together right away, we are a business that plays the long game. We'd love to help you now and maybe in the future do something together.